Well, thank you very much. Thank you to the organizers for inviting me to speak about novel strategies for glucocorticoid replacement. I must confess at the beginning that when I was asked to present on this topic, this is not a topic on which I present usually, because in fact, the novel strategies for glucocorticoid replacement have been developed mostly in the UK or in Sweden by my colleagues, and in Canada we don't have access to any of the new glucocorticoid replacement molecules, nor I think in the US, etc. So I have the chance of having excellent colleagues who are experts in the field, and Richard Ross, who's at the Sheffield University, has been doing this research himself, and I had invited him to the Canadian Society of Endocrinology, and last year he was a speaker at the ICE meeting in Cape Town, and I asked Richard if I could use his presentation, which I already had. So a large proportion of the presentation I'm going to be doing is coming really from Richard's work. So this is why I have indicated that it's a joint presentation between Richard and myself. So it's extremely important. You cannot live without cortisol. Cortisol has receptors in every tissue in the organism. It's essential for so many functions. As you know, it is very important in the regulation of glucose homeostasis, protein metabolism. When it's sufficient, everything functions correctly. When it's deficient, everything functions wrong. And when there's excess, there are effects which are so multi-systemic because there are effects of cortisol on every system in terms of glucose homeostasis, insulin sensitivity or resistance, effects on, through also its mineralocorticoid activity on the vascular system, on the sensitivity of the adrenergic molecules and receptors, so that control of blood pressure independently of volume, on bone metabolism, in terms of inflammation, in terms of control of our immune system, on muscle strength, etc. So it's essential for every organ in the system. Why is there a need for new therapies? I think that Bill Young was telling you we've had glucocorticoid replacement now since the 1950s. It was a Nobel Prize of Medicine for the identification of glucocorticoids, and it's been used since then. But the way we replace conventionally adrenal insufficiency, when you look at the outcome of those patients on long term, because we're not doing it in a completely physiological way, those patients are often, have been in the past, over-replaced, so that the standard mortality ratio currently for patients with chronic adrenal insufficiency is 2.7 increased risk of mortality. Every studies who have looked at quality of life of patients who have adrenal insufficiency will indicate that there's impaired quality of life, that the cardiovascular risk is increased, so mortality from cardiovascular outcome is bad. And when we give excess glucocorticoids, the very dynamic bone tissues, which require good equilibrium between bone formation, bone resorption, becomes disturbed. And there is osteopenia, osteoporosis in patients with excess replacement of glucocorticoid. So this is a situation currently with the current glucocorticoid regimens that we have available to us. And why is this the case? Well, when you look carefully at you're all familiar with the fact that there's a diurnal rhythm of ACTH and consequently of cortisol production by the adrenal. So there's a diurnal rhythm which is linked to the sleep-wake pattern, where generally the levels of cortisol during the night plunges and is very low, in fact, after a few hours of sleep. And about 2 hours before awakening, the peaks of ACTH and following the peaks of cortisol increase, so that they are maximal, in fact, about 2 hours before awakening, and are still present there in the morning. There's also an effect of food intake through amino acids acting on central neurotransmitters that will stimulate CRH, ACTH, so that after the lunch, there's also usually another peak of ACTH and cortisol, but then it decreases progressively during the night, the evening, the night, where it's low until the following awakening period. And when you look at the sophisticated ways with very frequent sampling, there's about 24 secretory events with pulses which are there at about 59 minutes interval, which have been estimated by Seifert-Lightman's group in normal volunteers. Well, our drugs currently have much difficulty in reproducing this diurnal rhythm. So another group, the group of Richard Ross in UK, also studied normal individuals and looked at the same types of curves in a very sophisticated way, with the nadir of cortisol, which is present from 23 o'clock at night until 6 o'clock in the morning. And then the peaks are increasing a little bit before awakening, maximal during the morning hours, and then decrease progressively during the day. Well, this is the physiological situation in normal volunteers. These were male studies. I showed you female before. Now there are situations like congenital adrenal hyperplasia where because the 21-hydroxylase deficiency, there's a decreased production of cortisol which is present, so that the negative feedback is decreased, which will result in an increase of ACTH. And because there's a block in 21-hydroxylase, it is a precursor of 17-hydroxy progesterone and adrenal androgens which are elevated. So when you try to correct patients for their deficiency of cortisol production, the resulting increase in the androgens almost require that you have to give supraphysiological levels of glucocorticoids to suppress ACTH sufficiently so that the adrenal androgens will not be elevated. So this is a situation where the stress of the lack of cortisol during the night hours amplifies, in fact, the defect which is there, which will cause even more problems than individuals who don't have 21-hydroxylase deficiency. And this is why there's been a lot of attention to use the developments of the new drugs and the replacement of cortisol replacement initially in patients where the situation is most difficult, as patients with congenital adrenal hyperplasia. What are the estimates of the level of production of cortisol in humans? You know that traditionally we used to give relatively large amounts of glucocorticoids in replacement, on average 30 milligrams of hydrocortisone or 37.5 or up to 50 milligrams of cortisone acetate. This was the way replacement was done initially when these drugs became available. And this is why we thought that the estimates of the cortisol production rates were higher than they are now, because more sophisticated approaches indicate that the levels of production are between 4.9 and 9 or 11 milligram per square meter, so that the real requirements of cortisol production are much less than what we thought before. And this is maybe why we were over-replacing patients previously. Now, which are the drugs which are available in different countries for replacement of cortisol deficiency? Hydrocortisone is the most physiologically similar compound as cortisol, since it is cortisol itself. I know that it is more expensive than other drugs. Maybe in certain countries, availability of hydrocortisone is less than maybe prednisone, but this is certainly the most resembling molecule, with 40 milligram of hydrocortisone equaling about 0.1 milligram of fludrocortisone in terms of activity. Cortisone acetate is a precursor hormone cortisone by itself is completely biologically inactive. It needs to be enzymatically converted through the 11-beta-hydroxysteroid dehydrogenase back to cortisol to become biologically active. Prednisolone is 4 times more potent than hydrocortisone, but it has 2.5-fold less mineralocorticoid receptor activity or affinity, so less mineralocorticoid activity than hydrocortisone itself. This is why when large doses of prednisolone are used as anti-inflammatory drugs, are preferred, because even with very large amounts of methylprednisolone, you don't tend to have the hypokalemia that you would have if you were using the same amount of hydrocortisone. Dexamethasone is 40 to 80 times more potent glucocorticoid than hydrocortisone without any mineralocorticoid activity. But all those synthetic drugs don't have exactly the same distribution and regulatory mechanisms when they cross the blood-brain barrier, for example. They're not metabolized like hydrocortisone is. So it's not only the capacity of the molecule to bind to the glucocorticoid receptor, but how it's going to be handled in humans and the different compartments for the long-term deleterious effects that glucocorticoids have. And I always have this bad feeling about the fact that people don't respect the effects of glucocorticoids. Currently in oncology, you know that dexamethasone is used as a candy because it's a very potent anti-emetic drug. So all these patients with the heavy chemotherapy protocols, they receive large doses of dexamethasone. People say, well, they're not doing well after their treatment because chemotherapy is bad, but I think that very high doses of dexamethasone with transient suppression of the axis and the risk of infections, etc. So I think these are issues which need to be thought of in terms of use of glucocorticoids for either replacement or for their other activities. So the classical table of the biological activity in terms of glucocorticoid potency, mineralocorticoid potency, and duration of action also are shown here, where hydrocortisone is given a potency equal to 1 for its glucocorticoid and mineralocorticoid activity. The half-life of hydrocortisone in circulation in terms of biological activity is about 8 hours. The half-life in blood is much less than that. It's about 60 to 80 minutes. But the biological half-life in terms of increasing blood sugar or in terms of suppression of the ACTH axis is half-life is about 8 hours. So if you compare with cortisone, as I said, this is just a molecule which needs to be converted back to hydrocortisone to be biologically active. So it has a little bit less potency because it needs to be converted. So it has a potency of 0.8 compared to hydrocortisone with similar half-life. Some people tend to like to use prednisone. I know that in certain countries, people use prednisone because it has a longer half-life than hydrocortisone. Personally, I never use prednisone. I prefer to use and convince my patients that 3 times a day of hydrocortisone, trying to mimic the different cycles of production of hydrocortisone, is a better way. And when you compare data for the deleterious effects of hydrocortisone versus prednisone versus dexamethasone, for example, on markers of bone turnover, it's a 3 times daily hydrocortisone, which gives the less toxic effects compared to the longer acting drugs. So the methylprednisolone, as I said, is about 5 times more active than hydrocortisone, and it has about half the mineralocorticoid activity as hydrocortisone does. And dexamethasone and betamethasone are much more potent, about 30-fold higher than hydrocortisone, but no mineralocorticoid activity. So this is why sometimes it is used like methylprednisolone when very high pharmacological doses need to be given for immune problems, like our patients who have severe Graves' eye disease, etc. And they're the drugs which are used mostly as topical drugs, triamcinolone. And finally, the melanocorticoid activity of Florinef is 200 times higher than hydrocortisone. And people tend to forget that it has 15 times the activity of cortisol in terms of glucocorticoid activity also. So these notions are important to understand the effects of the different steroids that we are using and comparing it with hydrocortisone. So the principle of replacement of glucocorticoids is that we would like to replace at physiological rhythms and levels. And this is the big problem with the current classical medication, because we cannot, when you give whatever form of glucocorticoids you're administering to the patient, when you use hydrocortisone and the patient takes his first pill in the morning when he awakens, well, he's 2 hours late compared to his normal cycle. And it will take an hour before absorption and biological effect. And this is why probably the quality of life of those patients is imperfect, because the levels, you're always late in terms of the first appearance of cortisol in circulation. And this is why often it is difficult to have normal ACTH levels in those patients when they have primary adrenal insufficiency. ACTH levels may be high, particularly because when they awake in the morning, their cortisol level is extremely low, and it takes a few hours before the first dose in the morning. So with the current availability of replacement, as we have some aging patients, and when my patients have to go up to go to the bathroom at 5 o'clock in the morning, and they go back to sleep until 7 or 8, I tell them to take their first dose of hydrocortisone at that moment, so that when they awake for good at 7 or 8 o'clock in the morning, at least they have had their first dose earlier, but you have to give the second and third dose earlier in the day so that they don't have high levels in the evening. So I never give doses after 3 o'clock in the afternoon, so that you try to have low levels in the evening and the nighttime. Another major problem with glucocorticoid replacement, or estimation of cortisol excess, is that we do not have good biological markers of the efficiency of cortisol activity. You know that, for example, for growth hormone, we have IGF-1, which is a very good marker of the biological effect of growth hormone in circulation. And this is a big lack in terms of our capacity to adjust well the treatment, either of glucocorticoid deficiency, even worse than cases of secondary adrenal insufficiency, where you don't even have ACTH as a marker if you're giving too much or not enough hydrocortisone. There are some biomarkers which are being studied currently. There's one messenger RNA which, within our different clinical trials in the treatment of patients with Cushing's disease which are not cured, particularly when we're using the anti-glucocorticoid receptor antagonists, which are being evaluated currently. So we hope that this is going to become available in the near future, but this is one of the challenges, that we don't have very good proven biomarkers currently. Patients require treatment, and as the knowledge of the amount of production of cortisol has become more precise in recent years, there's been a tendency now to recommend much lower doses of replacement of glucocorticoids than we did in the past, and I think this is valid. But I don't think that you have to be completely rigid about this, because it is true that the amount of production of cortisol is lower than we thought, but there's great variability in terms of the biological activity of the glucocorticoid receptor itself in different individuals. There's polymorphism of the glucocorticoid receptor, so some individuals are relatively oversensitive to glucocorticoids, and others are relatively resistant to glucocorticoids. So I think that you have to use your clinical judgment in addition to monitoring the blood pressure, the various markers that we have to be able to monitor. You have to take into account if the weight of the patient is maintained or if it's going up or going down, if there's fatigue, if there's nausea in the morning, etc., to try to assess for under or over treatment and not be too rigid, because I have some patients who are extremely well on surprisingly low amounts of 7.5, sometimes 10 milligrams a day of hydrocortisone. And some patients do require really more, 30, 35 milligrams. So although we try to adjust this so that the patients take on average 20 or 25 milligrams of hydrocortisone split into 3 doses, there is individual variability in terms of sensitivity that you have to take into account, so that the clinician has to be aware of these possibilities and make the adjustments according to the clinical response that you see in the patients. The Endocrine Society guidelines have been published in 2016. They were first presented in 2015, led by Stefan Bornstein, and this was published in JCM in 2016. And their recommendations is that preferably hydrocortisone should be used in doses between 15 to 25 milligrams daily, divided in 2 or 3 doses as tolerated by the patient. Or maybe because in certain countries the cost of hydrocortisone is much higher and not available, cortisone acetate in amounts of 20 to 35 milligrams a day can be used in the divided 2 or 3 doses per day. If this is not possible, or if the patients are not doing well, it's still acceptable to use prednisolone in doses of 3 to 5 milligrams per day. This is given most of the time when it's prednisolone, it's not 3 times a day, but it's usually twice a day. Some patients even take it only once a day. But it's not recommended to use dexamethasone as a replacement for chronic glucocorticoid deficiency, although in patients with congenital adrenal hyperplasia, this is still a regimen which is used in about 20 to 25% of patients worldwide when surveys are done of the methods of replacing glucocorticoids in patients with congenital adrenal hyperplasia, because dexamethasone at bedtime in small amounts is more efficient to block the excess production of androgens. So what are those emerging therapies? Because we're supposed to be talking not of old therapies, but of the novel therapies which are being developed. So there's really principally 2 molecules which have been developed. One which is called plenadrin. It has been studied mostly by Dr. Johansson, the groups in Sweden. This is a drug which is composed of a combination of immediate release hydrocortisone and outer layer coating with extended release. So the idea is it possible to give once a day this in the morning? And in order to prevent the fact that when you give hydrocortisone with rapid absorption and you give doses of 10, 12, 15 milligrams in the morning, often this will create really an initial peak which is too high compared to normal physiology because the binding capacity of the transport protein, which is CBG, is saturated with those levels, so that free cortisol levels increase proportionately when you give doses of 10 to 15 milligrams of hydrocortisone, whereas if you give a drug which will have progressive release, the amount of levels don't increase as much as when you give immediate absorbing hydrocortisone. The second kind of drug which was developed is called chronocort, and here you have an inert core coated with a hydrocortisone layer, coated with polymer layers, the outer enteric layer, and this will give both a sustained and a delayed release. And the objective here is to have something that will take a little bit of time to be going into circulation, that you would take at bedtime to try to produce the early morning peak of cortisol before you awake, which is the thing which we're not able to do now with the regular forms of hydrocortisone. So the proposal here is to give one dose at bedtime and one dose in the morning to try to mimic a little bit better diurnal rhythm of cortisol in normal physiology. So let's look at the results of Plenodrine given once daily with the composition here of the immediate release layer and the slow release core. It has about 20% less bioavailability than hydrocortisone itself. And if you look at the peaks, if you give patients hydrocortisone 3 times a day, as I said, you often have peaks which are above what is found in normal physiology in the morning or when you give the lunchtime second dose, or if you give it twice a day, you will have larger peaks. But with Plenodrine, there's a more gradual distribution throughout the day with lesser increase, particularly as you see here on this graph at the noontime compared to giving hydrocortisone 3 times daily. So it was shown that this is associated with weight loss compared to the weight gain that patients were getting on 3 times daily hydrocortisone, that the blood pressure of patients who were on Plenodrine were less than patients who are on conventional. And when you look at the results in terms of glucose homeostasis, that there was a reduction of glycated hemoglobin of 0.6% in patients who were treated with Plenodrine as compared to patients who were treated with hydrocortisone. So a few studies have corroborated this, that the outcome of those patients is better with Plenodrine than it is with hydrocortisone. So if you look at the daily plasma profiles here, once again, of normal individuals, the A panel, and in patients with adrenal insufficiency replaced with 20 to 40 milligrams divided in 3 doses, as I mentioned before, the peaks are a little bit higher in patients who are on hydrocortisone. And this is another study looking at patients on Plenodrine, and you see that the peaks here increases at 9 o'clock in the morning and then decreases gradually during the day, so that the integrated value of the area under the curve during the Plenodrine is less than patients who are receiving hydrocortisone 3 times daily. Now, as I said, in patients with congenital adrenal hyperplasia, the difficulty is to balance the effects of the replacement so that there will be sufficient replacement of cortisol and that the androgen levels will be suppressed adequately. Often it requires supraphysiological amounts of hydrocortisone to be able to suppress the androgens correctly. So if you don't replace enough the cortisol, you'll have excess androgens. And if you give too much cortisol, you do suppress androgens, but at the expense of having the side effects of cortisol excess. This is why Chronocort was being developed and tested initially in patients with congenital adrenal hyperplasia. So through a collaboration between the group of Sheffield, Richard Ross, and Deborah Merck at NIH, the first studies were done in patients with congenital adrenal hyperplasia. And here again, the composition of the molecule is such that there will be some delay in the initial release, so that when you take it at bedtime, the peak cortisol levels will occur at the time that usually the physiological levels of ACTH and cortisol appear during the hours before awakening. So with twice daily Chronocort and this study, the diurnal rhythm of cortisol here are shown compared to the normal circadian diurnal rhythm. And you can see in blue that it's not exactly the same, but it mimics better the diurnal rhythm with the appearance, in contrast with when the patients are on hydrocortisone, that there is already between 5 o'clock and 7 o'clock, cortisol levels do increase and mimics more what happens with normal physiology. So here in patients with congenital adrenal hyperplasia who were on Chronocort 20 milligrams at bedtime and 10 milligrams in the morning, the curves of cortisol during the day, sampled during the day, resemble a little bit more normal physiology than the hydrocortisone curves that I showed you before. And in terms of ability to suppress the androgen, so this is monitoring the levels of 17-hydroxyprogesterone with Chronocort versus conventional treatment, you clearly see that in black, the patients who have been on Chronocort for 6 months have much more normal ranges of adrenal androgens than patients who are on hydrocortisone replacement. And ongoing studies in phase 3 with a much larger number of individuals, 122 individuals with congenital hyperplasia, also showed the same results here. That androgen control were at similar or lower dose compared to the standard treatments, and was well tolerated and provided a natural overnight cortisol release. So these studies are still going on. Chronocort is not available yet for treatment of patients. It's still investigational, whereas Plenadrin has been accepted. It's available in Europe, but it's not available in countries like USA or Canada. And I don't know, is it available in Southeast Asia here? You know if Plenadrin is available yet in these countries? No? Okay. Well, I think that the companies, as soon as now they're conducting studies in chronic adrenal insufficiency also, I think it's been very successful in congenital adrenal hyperplasia. And I think they plan within 2 years approximately to ask for permission to license this drug, the Chronocort, and Plenadrin, I suppose, will become more widely distributed, although I was supposed to be one investigator for a study for Plenadrin in USA and Canada, and the company decided they did not want to do this yet because FDA and the Canadian Drug Agency required more studies than what had been done initially. Now, in children, there's the particular problem of the doses of glucocorticoids because according to weight and availability of the different pills currently available, this poses a particular problem. So there's new drugs because either they were not available or batches were prepared by local pharmacies or by hospitals, etc., to be able to administer smaller doses of glucocorticoids. So there's a new drug which is called Alkin-D, which are granules where it's possible to have much more defined doses, smaller doses, which are applicable to children. And this is something which is also under development recently and has been shown to give interesting results in the first studies that were conducted, but we're awaiting larger studies in terms of the capacity to adjust the treatment doses more easily for very young infants, small weight, etc., particularly the ones with congenital adrenal hyperplasia in young infants. Other approaches have been in similar way as people do insulin pumps, to install pumps to infuse hydrocortisone, because clearly with pumps it is possible to modify the doses so that you could provide peaks during the night to reproduce the normal physiology. Obviously, this is a very heavy way to be doing this. It has been applied to very difficult cases like very severe congenital adrenal hyperplasia patients who are very difficult to control. You know that even in some cases it's been proposed to do bilateral adrenalectomy in such patients to be able to replace them with more physiological levels when it's difficult to control the excess of androgens in certain patients who are particularly difficult. So this has been done in small groups, small studies, and clearly it is possible to get better curves, but you understand that this is not something that's going to be used very widely to replace patients with adrenal insufficiency. But the principle has been shown, and with very sophisticated ways to analyze brain function and brain waves, because glucocorticoids are very important for the brain, and we have either deficiency or excess. There are very profound effects in terms of many of the systems. We thought initially only on the limbic system, on memory, etc., but in fact, our studies in patients with Cushing's by many groups have shown that there's very deleterious effects on the brain. And if you monitor the different patterns of brain activity in patients that normal individuals, you treat them with methyrapone and you give either hydrocortisone at 20 milligram per day, you give Plenadren, or you give the new long-term formulation, you can see that there's very different patterns of brain activity in such individuals, showing that the normal physiological levels of glucocorticoids are important for very sensitive measures like brain activity in these patients. As Addison's disease is an autoimmune disease, there are some studies which have been conducted in terms to try to modulate the immune response of patients with Addison's disease to try to prevent, in fact, the development of Addison's disease. This is a little bit beyond, we're asked to speak about new approaches for glucocorticoid replacement. Well, one new approach would be to try to prevent the development of adrenal insufficiency. This is a little bit outside of the scope, really, of this presentation, but there are studies which are looking at the possibility of modulating the immune response of those patients and to try to prevent or to retard the appearance of their disease. So in conclusion, I would like to say that the treatment is to try to replicate physiological levels of glucocorticoids throughout the day, and that there's emerging therapies which include smaller doses for more accurate dosing in children, of giving a dose of longer acting glucocorticoid with not as much of an increase with the acute doses for once a day for easier use, or to give a drug which will give a peak in the morning. Personally, I think it would be very interesting to do a combination of Chronocort at nighttime and of Plenadren in the morning as a design of a study to try to reproduce better the normal physiology. But clearly there is hope that we will have better treatment availabilities in the near future, and we'll be able to conduct even larger clinical trials to get better details about the outcomes using these approaches. So I'd like to thank you for your attention, and I'm open to discuss this with you. Thank you very much.